Good morning, everyone. Thanks, Erin, for the introduction. I think you lay out very well some of the things I'm going to talk. Just one disagreement with you is they say not all economists believe the market are the best solution for solving the problems. Certainly not in health, and certainly not in education, as I hope we're going to show in the next slide. So good morning. First of all, my name is Edson Araujo. I'm a senior economist at the World Bank, and I work, from the last years, I've been working most on the health workforce issues. And my work at the World Bank, of course, it's a development institution. So much of what we're going to talk here is about health professional education and labor markets in low and middle income countries. But of course, I think the problems are very similar, as you're going to see. And I hope when it's not very similar, we can always discuss what's the parallel in terms of the trends in the US. On the other side, I understand the foreign focus and global, not only the US. But it's important to make this point at the beginning. So the first point is, much of what we're going to talk today is based on this publication, recent publication by the World Bank, and I think it's being circulated among the participants of the forum. And I just want to acknowledge my co-authors, Barbara McPake from the University of Melbourne, Alice Square from New York University, and Agia Mahathi used to be a consultant at the bank. So while you did this, the motivation for this publication is we are trying to understand what's the market forces that drives career choice of health professionals. Health professionals. From one side, we understand how the market forces influence people's choice, but from the other side, how the education sector, how the education process, how the training process influence also the markets. So in a way, we are looking at both sides and supply and demand of this. This is a brief overview of what we're going to talk. So first is a brief overview of the framework to analyze healthcare labor markets. And then you're going to talk specific about the topic for the discussion, which is the interaction between health markets and education markets, and what's the conflicts or the tensions and what's the imbalances from this. And that I highlight the interaction between needs and demand, the supply and the training. And we're going to show how these interactions result in some imbalance. Some of them are already mentioned. Interest is good to look when you see a distinction. It's good to see how the trends on demand and supply, not only in the US, but globally. You see there's an imbalance in between the growth of demand for health workers and the supply, the production side. And I think this is going to be interesting for discussing in the next 1 day and a half. And then I'm going to give you some facts about the cost of health professional education. Of course, in this area is a more complicated area because, first of all, the data are not available most of the counts. Of course, the US is in a privileged position in terms of data availability. But on the other side, we're going to see that's a very complex, right? It's a very complex. We have several funders, and the channel of the financing flows in this is very complex. So it's difficult to establish some, let's say, accountability or cost-effectivity analysis. As you see, as I hope we're going to show, there's very few studies on cost-effectivity analysis of health professional education. One of the reasons is the data availability, and finally, some ideas about health professional education for universal health coverage, and following up what Erin said about the momentum to transform healthcare. One of the flagship action in the bank for health in the moment is universal health coverage. And the bank has formally endorsed this, and it's advising countries to expand coverage to achieve universal health coverage. And more recently, under the leadership of Tim Evans and my colleague here, Oki Pannenberg, and another colleague from the bank, Christoph Herbst, we wrote a paper about health professional education and challenge for universal health coverage. So by the end of the presentation, I'm going to bring some of the ideas we have been discussing for that. And this report is going to be released in the November forum, the World Innovation Summit for Health, which is a forum that happens in Doha, in Qatar, in November. So this is basically what we're going to talk. So I'm going to start here from, as I said, the framework for health labor market. That's something we've been working in the bank for the last years. Not only the bank, WHO, and others also have been working similar frameworks. But basically, it's trying to understand the market forces around demand and supply of health workers. Of course, here today we're going to talk more about the supply side. But one of the things I think most of you will know, and I hope you're going to discuss more, Also, there's this link, direct link between demand and the supply of health professional. And of course, specific is how the costs, how the demand for healthcare influence the health professional side, the production side, the training side. And I hope you're going to see there's some equivalent movements, right? The market signals that are being given for the demand side influence the supply side. And of course, you look at this, what's the result of the labor market in terms of employment, in terms of numbers of people, in terms of composition for the workforce, in terms of the distribution for the workforce. So most of the countries have challenges in bringing people into rural areas. In terms of composition, you see over-specialization for workforce in most of the countries. And of course, some countries face challenges of migration, and of course, performance as well, right? So you look at this market force driving both sides, the supply and demand. And one of the things is not being discussed here, but I understand you're going to be discussing the breakout session, is about the employment contribution for the health sector. As we know well, the health sector represents a large share for the labor force in most of the countries. I think the best example of that is the US, where the labor force represents about 10% of the total labor force, and is expected to increase to 20 in the decades, I think by 2020 or something. And even more interesting is the employment in health is counter-cyclical. Even the last recession in the US, the jobs in the healthcare industry kept growing. So it's also very interesting to look at this on the perspective of the employment generation. And I don't know, many of you probably have seen the recent UN report. Sorry, the report of the UN High Commission on Health Sector Employment and Economic Growth basically is showing the pathways of the influence between health sector employment and leading to economic growth. But the underlying assumption, underlying motivation is to show, look, the health sector is a very large employment sector. And despite of the challenge we have in terms of providing services, as Erin very well put, we also have to look at this as an employment generation sector. And of course, this brings challenges again for health professional education. What type of professional you're going to produce, and what type of skills you're going to give them to go to the labor market. So I put this example of the health workforce dynamics in Togo because I think this is one of the best graphics that illustrates when you're talking about labor market forces in the health sector. Because you see from 890 doctors trained in Togo, 2010, you see how many migrate, how many are unemployed because they don't accept the condition of employment, and how many go to practice in the public sector and the private sector. So basically, from 890, we have only 17%, 8% of the population, and you see majority in the, of course, the urban areas. That's the challenge in most of the countries, not only in Togo, but most of the countries. And those, you see the challenge between public and private, and of course, this is not necessarily bad. We need to look at the effect in terms of quality, in terms of costs, in terms of access to healthcare. But the main point here is to say, from 890, only 67% are active in Togo. And among these, only 70% are actually 8% of the population. So the view of the labor market lens is to say their market forces influence this situation. And the idea is that you're going to look at it specifically market force to understand how this happened and how it can be changed. So going more specific on the topic here today is the Lancet Commission in 2010. I'm sure everybody is familiar with the Lancet Commission. First, I already pointed to this interaction between market forces and, market forces in healthcare, market forces in the education side. Basically, it's the education system and the health systems. And the interaction is mediated by the labor market, right? So one of the things that's interesting in the Commission is they pointed out that the challenge here is to transform the needs, and needs from both sides come from the population, into demand, right? That's the main challenge from both sides. Not always the needs are transformed into demand. Of course, from the health sector side, from the healthcare side, this is something that the health economists have been working for years, in terms of say, look, this is a market failure because not all the needs are transformed into demand. And one of the reasons because there is information and gaps. So basically, is patients they know less than the providers, right? But you're going to come back to this. But I just want to point that the Lancet Commission in 2010 already pointed to this interaction and the importance of look at this interaction to design policy for health professional education. So then here we have this let's call modern that I think that we're going to use for the rest of the forum is a simplification what the demand side and the supply side for health workers and how it is influenced by each other, right? So for one side, of course, you have the population needs that not necessarily going to be actual demand for care because that's depends on the perceived need and also depends on the willing to pay for it, right? And of course, you're going to see later, depends also on the ability to pay. That creates some consequence in terms of access and equity. From the other side, you have the supply side that influenced again by the needs of health workers training, and of course the health workers' careers. Not only the need for the health workers, but also how the health workers perceive those needs and how they make the decision in terms of employment and training. First, of course, and second, in terms of employment. But again, the difference here is this: not necessarily everybody are going to be trained; they're going to be practicing, right? As you see in Togo. So that's depend also on the availability of individuals willing to work, given the working conditions, given the wages and other employment conditions. So this is what we're going to be working for this presentation. And what they're going to do is going to present some aspects, some issues in each of those, both the demand side and the supply side, and as much as possible, some evidence to illustrate the points. So the first thing, and that's when they come back to the market, and not necessarily works well in the health sector, is that the market for training, let's say, or if you prefer the education system, has some is skewed by the same market failures that we have in the healthcare market. And the first and the main one is, of course, as I said, is information gaps, right? So consumers or patients, they don't know as much as the providers, first thing, but also it means that not necessarily they're willing to pay for it, you're going to be the same as the informally willing to pay. Like sometimes people are buying things that not necessarily the best return for the spending, right? And from the other side, the suppliers also can induce supply, provide services that are not necessary for the patients, for the consumers. So information gap is the main one, and then it brings the problem that the wage rate reflects the wage rate that do not reflect the value of health professional if you measure it by the impacts on public health, right? As I said, both from the demand side, from the individual side, and from the patient side, they tend to not value the health intervention as they should, or most of the time. Of course, information these days are much more available than in the past. You have like Dr. Google, right? But the other side, the supply side, also there's a tendency of supply-induced demand. So information gap is the main one of the market failures. The other market failure is the weak demand. As we know, the distribution of ability to pay is often inversely related to the needs, inverse care, healthcare law. So the poor, the rural areas, they usually have weaker demand to buy the service they need. And often the government is not able to fulfill that need. So I would highlight here weak demand and information gap as the main market failures that you're going to see influence also health professional education and the allocation of resources into health professional education. So in terms of imbalances, well, so what's the result of this? What's these two market failures result in terms of health professional imbalance, or if you prefer, healthy labor market imbalances? So of course, first the shortage. There's a global health work shortage. Now it's estimated in 7 million. By 2030, is estimated to be 50 million. So it's growing, the shortage, not even reduced, it's growing. And this estimate is based on the current, the status quo, based on the same rate of demand now, based on the production now. So it means if you take into account population aging, chronic disease, and some of the changes that I mentioned in the healthcare, it might even be bigger, even be larger, the shortage. Skill bias, as you're going to see, over specialization, the challenge between balance primary healthcare workforce and the specialist workforce, and the more distribution, as I said before, rural distribution, workforce tend to be concentrated in urban areas, and of course, international migration that many countries face challenge. So going specifically to from the labor market perspective is the wage rate is an important influence of education and training choice. Of course, not the last one. We have some discussion before. Of course, other things influence people's choices for careers, lifestyle, number of hours of work, vacation time. All these influence also individuals' choice for employment, for training. But from an economic perspective, from a labor market perspective, wage rates is a key variable to be observed. And then economists measure this based on the rate of returns to education. Basically, is what's the return you're going to get if you invest time and resources into some training. And of course, here you need to distinguish between private returns. That's when you say individuals make their own choice in terms of the training. But we argue that more and more you need to look at the public return and the social returns. We're going to come back to this later, and I hope it's going to be one of the topics of the discussion these days, is to say, as Erin said, if you let market alone, the private returns are going to be more influential because people are going to make the choice based on how much they're going to get in return of the education investment. But if you look from a social and a public perspective, you probably don't want to guide the allocation of results based on private return. You probably want to look at the social returns, right? But I hope we can come back to this point later. So healthcare marketing may not be reliable to regulate health labor markets, but because it sends signals via rate of returns to different type of health professionals. So basically, you look at the market to see what's going to give more return, both given the investment that I'm going to make, not only investment in terms of financial results, like student loans, but also in terms of time. Longer profession, longer time I'm going to be training, more time, more return I'm going to need. Right? I was looking recently about the return, for instance, for MBAs. It's very immediate. You go for 2 years, and right away you can go for a job. I think it's like 90,000 salary. While probably medicine and other careers, you have to go much longer to achieve that level of income. You study much longer, maybe even higher, but means you're going to spend more time in training. So one also important point here that I think you need to highlight is this link between the cost of education and the cost of healthcare. So patient demand and insurance reimbursement fail to flow according to public health needs. So basically, if you're going to pay more for high specialized service, there are going to be more signals to rate of returns because individuals are going to look and say, look, those are the services that have been better paid. That means that we're going to get higher compensation for that. So this link between cost of healthcare, what are we paying for healthcare, and the decision individual makes in terms of training and career choices is direct. I think Erin mentioned that in the opening remarks. Another important point here is the technology change. The increasing use of technology in the healthcare changes the elasticity of demand for high-skilled work relative to low-skilled work. What means is, basically, we're going to be more, the healthcare employers, I say, are going to be willing to hire more people for higher skills because you have more complex technology to be used. And also because we as a patients or consumers are going to be demanding for those higher technology. And that also makes it difficult to substitute high skill for lower skill. There's so much scope for getting individuals for lower training to perform activities that will require higher skills, right? I'm going to show you some graphs, some data about that. So come back to this. The model is we have on one side the population healthcare needs are influenced by the burden of a disease and the population side. But what we have here is the market sends signals to rate of returns. You say, what's the profession, what's the cadres that give you a higher rate of returns and that influence individual's choice. The patient demand and insurance, as I said before, fail to reflect the value of health professional education if you measure by the impact in terms of public and social returns. So in the key relationship here is the compensation and the shortage, right, or surplus. So if higher compensation, is likely to drive more people for those professionals, those cadres. Low compensation going to drive people away from those cadres. So, and then what we have is jobs at the urban and hospital, focus on acute care and treatment of EU patients. We have patient based on volume, not on quality, and they have access to care based on patient's ability to pay. So those are the imbalances you see, right? The results of this, we are sending signals to people to make the choice based on that. So if you're gonna send people signals to the market, that's what we're gonna get, right? And that's pretty much the reality is there's emotion of the count, right? So I think one important aspect of this is making this link between what are you paying for healthcare and what the decision the individuals are making. So let's see some evidence, right? This is a paper by 2001 by someone, I think it's from University of California, showing the rate of return from different professions. So I try to put all, just make sure that we can, maybe can in the discussion can come back if you are interested. But you see the higher rate of returns and also taking account the years of graduate and the median annual earnings, right? And you see radiology, non-invasive is the higher rate of return, almost 40%. When you compare it to family practice or general pediatrics, 13, 14%, 17%. So basically, what we're saying is the rate of return for those professionals at the top are much higher for those on the bottom. This is some mistake here. They're higher for those on the bottom, right? And here, just the same information, but to rank it. I like more the table because it gives both the year of the time of graduation. As I said, also need to take into account the length of the training, and of course the median annual income. And that's the median. Of course, probably there are some variation within each category. And this is a paper 2015. It's a very more recent paper, and you see the annual ordinary income, and that's before tax for different professions, different cadres, and you see a cardiologist is much higher than the others. So my point here again is to say, this gives signals to individuals when they make the career choice, right? Or the training choice, if you want. And I hope you're going to see later is how this also influences the other side, the supply side, the production side of the health workforce. And this is not the US, of course, this is a global trend. And you see here from this graph among the OECD counts, selected OECD counts, you see that most of the counts, specialists make more than general practitioners. Of course, this is the growth rate. So between 2005 and 2013, the salaries increased, specialists grew more than for general practitioners, except in Austria, Belgium, and the Netherlands. Maybe Oki can tell us about Netherlands in the discussion. But it's unusual. So in most of the countries, you see the trend is different, right? So it's not an only US problem. But here there's an interesting example about China, because this shows the opposite directions. 2 years ago, the bank made a large report on healthcare in China. And one of the things you observe is, like say, healthcare salaries in China is lower compared to other professions. Of course, similar education attainment, right? So what you see here, the base salary is low, so there was embedded incentives for health professionals to overproduce service. They produce more service because they need to top up the income. So what the result is this, one of the most known thing is violence against doctors. You see, for many years you saw in the press, doctors being killed, they be abused in the healthcare, in the hospitals in China. So, but the underlying motivation is, as I said, the salaries are low, so they have to top up, they have to overproduce medicines and tests, and some evidence of doctors seeing 40 patients a day. So there is clearly a tension with patients, So, but what we see in this, in terms of the consequence for health professional education, first is only 40% of graduates are going to, at least in that year, 2010, 11, were going to clinical practice. Physicians, they are dropping to go to biotech industry or pharmaceutical industry, sorry. So there's a very low rate of maintaining the graduates in the healthcare sector. They go for other parts. And the second is also it starts to give a negative signals for the students applying for medical education. Because one of the effects, one of the evidence we found is those students, they have to do the exams, no, as much of the counts. So basically, those who choose medicine were more and more those with lower grades. So those with higher grades start to choose another profession because basically the prestige of being a physician in China reduced over time, given the scenario. Of course, there might be some areas of excellence and some big hospitals that pay much better than the average. So, but this is a clear example of the other way around, right? I was giving an example of the US, Europe, where the higher salaries influence more people going to practice certain specialties. But this is the other way around, you know? Like lower salaries and lower prestige are putting people away for medical training. So going back to the model is, what we have seen is the market signals, if let alone, they're going to result in neglecting the poor and the rural and the remote population, and they're going to also result in neglecting the preventive and promotive interventions, and also not necessarily rewarding performance in the way we need or you would desire it to. So let's go for the other side now, talk about the supply side. I'm sorry to put this very in a simple way, but everything in economics, as you know, is about supply and demand. So it's good to keep the thing about that. However, I understand we are much smarter than that. So from the supply side, what we have the production. The training is influenced by the model of training, how you train people, you know, what's the curriculum, what's the content of the curriculum you give them, what's the exposure they are having on doing the training. I probably will not say too much about that because I'm probably the one economist here. You all probably are most health professional educators, so I'm going to keep the part I'm going to talk about this as little as possible. But also influence the regulation, influence the supply side, the results available. That's the topic of the forum, right? The finance and how you pay for that. One interesting factor, I'm going about to say later, but it's good to point now. The Lancet Commission, 2010, points that only 2% of the total healthcare expenditure, like 5 trillion, only 2% goes to health professional education. It's around 100 billion globally. So it's a very little investment for a sector that's mostly based on labor, very labor intensive, you know. So I think when you're going to discuss about finance, you need to think about that we spend very little. You know, 2% is really, really very small share. But also we spend bad, you know, because you're going to see the tendency of specialization. You have a challenge of shortage, 15 million is estimated for 2030. We have the composition, the skill imbalance. So I think probably if you want to start a discussion about financial professional education, you need to focus on these two points of information, right? We spend very little, and we spend probably not even very well, not very well located. They spend it. So of course the resources, the influence, but also the amount, but how you finance the results, right? We're going to see later about some information about student debt, the faculty, and of course the applicants. You know? The rate of returns and the prestige and the quality of life, as I said before, the things influence the supply side. So what we have here, we have inadequate scale and narrow scope of education institutions. We have curricula, not necessarily curricula follows what is the skills that are marketable, because they need to respond. Like say, if individuals are looking, the rate of return for certain specialties of certain training is giving higher returns, they're going to demand that. So what most of the time happens is the education institution follow that. You know? They offer those training because they know they're going to be people applying for those trainings. Accreditation licensing often function as barrier to entry. No, that's a topic that I think also is very important to discuss, because of course you need some quality standards, and the quality is very important here because of the information gaps. So you don't want people who are going to practice without knowing what they should do. But at the same time, you need to look how much, to what extent the accreditation also creates barriers to entry, right? And the weak pool of eligible students, you know, especially if you look at medicine, most of the counts, and especially low and middle-income counts, are very, the pool of applicants are very homogeneous. You know? Used to be the rich and the better off in these countries. You know? It's very difficult to find some people from poorer backgrounds in medical schools in most of the low-income counts. So what we have here is you have a skill imbalance in terms of results. As you see, you have the imbalance between specialists and primary care cadres, over specialization as a result of technology change, as I mentioned before. And high cost of training, right? That's probably again the one thing to discuss here. What the cost of training, and if you look at the evidence, you don't find much evidence in terms of a specific cost of training a medical doctor, a nursing, other cadres. So, okay, some trends in terms of supply. Um, what you see here is say the population is growing globally, but the supply is not catching up, right? So um, um, so you see, that's only doctors. Now we have a discussion before here. Probably you have seen increase in other cadres, which probably is good because you need a more balanced workforce. But so far, I mean, it's likely to be the case. I didn't find any graph that can show that. But still, even if you say that's a positive way, but still, it's clear that we need more doctors worldwide. No, and then I show you some examples here. Uh, yeah, this is some World Bank paper 2016, so very recently, is estimating the supply demand of workforce by 2030, and the need line is from the WHO report on health workforce strategy for 2030. Basically, they estimate the need for the workforce globally, and based on the 4.5 health workers per thousand population. And I just showing this because it's interesting to see in most of the countries, demand are going to raise, and in a very high rate of increase. But in most countries, apart from high income countries, the demand is much higher than the supply. So the supply, again, take into account the current status quo, right? The rate of replacement, the rate of production of health workers. So you're going to see most of the countries, we see the same trend. Needs or demand are higher than the supply side, the production side. So we are not producing in the same rate as the need is increasing. And then that's the question is, I mean, this explain the shortage we have. What's the problem in the supply side that's not catching up? We're going to discuss more this. Um, interesting is true. This is the U.S. You see the lines on the top are the demand for certain gives different scenarios. I think this paper is being distributed by the committee, and the lines on the bottom at the bottom are the lines for the supply side. And you see for most of the scenarios, again, the supply side is not respond the demand side. And that's interesting for the U.S. because between 2014 2025. Population expect to grow by 8.6%, but the demand for physicians I expect to grow by 14%. But still, the supply is not catching up, right? The supply is always lower, and they expect to increase a much lower rate than the demand and the population growth. So basically, it's 5% increase in the supply side. Basically, if you take into account only population growth, the supply side is not catching up. So then what's happening is, and that's not, of course, not a trend on the US, as I showed in the two slides before. This is for all counts, and this is divided by income groups. But then what you see is the public sector on one side is not able to respond to the increase in demand for health workers, and you see the private sector growing most of the counts, right? This is about Brazil, but could be the same for India, could be the same for Indonesia. China is more controlled, it's different. But most low and middle income counts, that's what you see, the explosion of private sector and training. And again, it's, however, growing, not necessarily mean that it's catching up with the increase in the demand. And even if you say increase of the current shortage, right? And of course, this brings the challenge of regulation, right? The quality. If you see that's the case in Brazil, you see the students have the test when they graduate, and they tend to be lower than the scores of those. So the private student, the students coming from private schools, they tend to have lower grades than those in the public schools, and this actually has been going down in the last years in Brazil. But that's very similar thing, a situation in India. There's plenty of evidence about the issues, the challenge of regulating quality of medical health professional education in India, but also in Indonesia and many other countries. I mean, in this sense, I think probably the U.S. is much better off. And actually, I work in a project in the World Bank project in Indonesia. They learn a lot from what happened in the U.S. in terms of accreditation and quality control. Actually, the previous meeting was about accreditation, right? so, um, so going back to this is, I say is, from one side you see the supply side is not catching up, and then if you start to talk about the finance of health professional education, this is interest about this is the debt to income rate, right? Basically, it's those lines at the top, which are family medicine, psychiatry, emergency medicine, obstetrics, etc. They have higher debt to income rate, which means is they're going to use a higher proportion of the income to pay back the student loans, right? This is more specific to the US. And you see, again, no, first thing you're seeing is those at the bottom of orthopedics, cardiologists, they have lower debt to income rate. So people are paying a lot more, of course, for education. But in terms of you compare what's in terms of they're going to make in terms of salary, you see the difference across profession, across cadres. And again, this is influence how people make choice in terms of the training, right? If you want to go, what Arian is saying in terms of rebalance workforce and rebalance health service delivery, you need to think about this, no? Because this shows us how people are paying for healthcare, or sorry, for training, you know. So then you come back to my model, no? Not my, but the former model, the interaction between demand and supply. So for one side, from the demand side, what you see is an ejection of the pool, and the rural and the distribution is skewed in most of the count. And you see also the challenge in terms of balance the workforce in terms of preventive and promotive, and also in terms of reward and performance. And again, I think it's very important to look at this link between the cost of care, so what are we paying for, and what are you paying for health professional education. No? I hope I show you this, to the market signals, these influence the outcomes of that, right? From the other side, what we have the skill imbalances, especially as primary care, over specialization, and the very important topic, the high cost of training, right? You know, I think one of the important things here is to look out is the high cost of training is only health or also in other sectors, right? The training has been increased in other, like say, engineering, education, etc., law, or is only very specific to healthcare, right? Of course, healthcare, the investment for producing health professionals much higher than, for instance, in law or economists, right? So it didn't result in labor shortage, unemployment, or underemployment. I think the example I gave for Togo is the best example to illustrate those imbalance, right? So I think the main point here to be make is this interaction, no, between the demand side and the supply side, but also what's the signals, no? What the market signals from both sides. No? For one side, what people are paying for health professional education, and you've seen it's been higher and higher, and you see more private sector participation. Most of this cost also comes to the individuals. So it means they're also going to have even more incentive to look for those professionals that give higher returns, right? And from the other side is higher returns resulting in, because of a higher demand for specific services, going to also give signals to the supply side. So they're very much interlinked, right? That's what you call economists call market. So basically, this is a summary of what we're talking about. You know, you see the number of applicants depends, of course, on the private return from the individual perspective, right? The education institution, the capacity to absorb those who are interested. That will result in graduate numbers. Of course, this is going to come to the market. You're going to decide the market is going to allocate, and they're going to have shortage or surplus of health workers. And as I pointed before, and I hope it was clear, that is, if you let the market alone, give the market failures exist in healthcare, we're not getting the best allocation of results. Certainly not. You can even get higher returns of private, but you definitely not get the best returns for social returns of investment in education. So the professional compensation, that of course influence the private return. And then of course, as I said before, there are many other factors influencing those, let's say, those pathways within the decision for training and career choice. So, and I think, of course, we're going to be discussing about this part specifically, but looking at the broader determinants of this, right? So finally, a few more slides before I get too tired, is about the finance of health professional education, right? I'm not going to all the details of this. I hope this is going to be some food for thought in the discussion, but also in the breakout session, is you see the first thing is very complex, right? This is from Alex Preck and colleagues from World Bank publication 2013. You see, it's very complex. You know? We were discussing 2 days ago, not 2 days ago, a few weeks ago, about accountability or cost effectiveness analysis of health professional education. But how are we going to identify this? You see training is being financed by students, by the hospital, because they do during the residence. They also get paid. I think the Medicare here pays for the residence. In the developing world, you have donors. Of course, we have the hospital, both in the private sector and public sector, etc. like that. And you have the commercial lending. So there's multiple sources of funding. And even if you put more, we discussed this a few weeks ago about research. You know? If you think about medical school specifically, there's a lot of funding for research. And then that research pays out part of the salaries of the faculty. So when you're going to look at the return of investment in health professional education, you need to face this, right? And then if you think about how you're going to prioritize investment, how you're going to finance, you need to think about this complexity, right? Of course, I'd say in the US, you don't have much donors. I probably have some non-for-profit organization financing, right? Because this was very much based on the developing world. But to some extent, it applies to the US. So another interesting thing is about the specific cost, right? If you look at the evidence, we don't have much evidence in terms of the cost of the education. Of course, in part because of this complexity that I just showed you, but those there are no data. No? If you look at most of the countries, there are very few studies looking at the specific costs. And this one is specific in Ghana, and it shows the cost of 20 different cards. And you see, of course, that's one point for discussion. It was one of the recommendations from the report. They say, look, you invest too much to produce some cards, and so other cards are much lower cost, so you need to think and prioritize the investment, right? It sounds to be obvious, but usually it's not done like that. You know, that you say it's much more expensive to train a specialist than train, let's say, a midwife, right? But just an example of says there are not much examples of this exercise. Of course, I'm talking about the developing world, and I don't know, the US probably have more. This again, the specific in terms of the cost of it cost item in terms of the training, and again, this is for Ghana 2007. So my last slides on this is about. So you talk about rate of return, you talk about market force, we talk about how the supply side responds to the increased demand, and how the supply side also is influenced by the demand for healthcare, right? So what do you need looking forward? What's what should look like a workforce that is for universal health coverage? And this is a graph from the paper that I mentioned at the beginning that some Tim Evans and other colleagues from the World Bank are working. Ockmanenburg is one of the authors. I mean, this is a bit of advertising, but that's some of the discussions we are having at the moment. You know? Is to say, if you look forward, what type of workforce we want, and what the changes we need from both sides, from the demand side, for healthcare service delivery, and from the supply side, you know, from the health professional education side. So you need jobs balanced across primary healthcare and curative needs. No? We need jobs located closer to population needs, no? Those who have a higher impact, or those who have higher social returns, let's say. We need payment based on outcomes and to incentivize team-based service delivery. You know? Some of the things that Erin said in the beginning. You know? So it means is if you want to change health professional education, the finance or you need to change also the way you deliver service. You know, because it's a clear marked signals given to people to say, look, I'm going to invest from both sides. From the individual side, I'm going to invest in those professions that give a high return, but also from the supply side, you know, private schools going to be open training for those training that people are demanding, right? Because that's the nature of the investment, right? So from the supply side, you need a broader and strong pool of eligible students. No? We need more diversity. As I said, most of the low-income countries, people going to medical schools, they have found very privileged group of the population. Like say, again, if you talk about Brazil, there's some initiatives about quotas, like a quota, sorry. They give some seats for people coming from public schools, etc. But there's some concerns about how it's going to influence quality of training in the long terms. But those are some initiatives to reduce this concentration of very homogeneous group going to medical school, but to less extent, but similar to nursing school and in general to have professional education. You need greater scale and scope of education institutions. We need step-ladder career opportunities for career development. If I remember well, the Philippines is a good example that allows people to move upward within the health employment, like can start as a nurse and have some more training and be upgrade, and go up. And of course, competence-based curriculum. I'm not talking too much about this, but what we see, as I said before, with the technology and change in healthcare, you see more and more investment in higher skills and not much on the skills that we identify disease and disease that are closer to needs, right? So if you have those changes, both in the demand side and the supply side, we tend to going to have a workforce that's adequate in the numbers, appropriate in the skill mix, and evenly distribute and perform well. Of course, this is ideal, right? But not change those two aspects, the aspect of demand, the supply, we're not likely to get that. So one last point, I think I'm not going to the recommendation because I'm going to just leave there because I think it reflects some of what I said already, but is going to be interesting for the discussion. I think some of these points are going to come up in the discussion. But one last point I want to make is about the what we see the high rate of returns for high specialization. Right? And of course, we can say that factors influence the high rate of returns, such as because cardiologists work longer hours, or because cardiologists spend more time in the training, or even because of the skills, they earn more. And there was this interesting study in 2013, if I'm not wrong, looking at this, how each of these factors influence the returns observed. And they found that only half of the high returns for I'm going to bring you to the graphic, it's better to visualize. Oh, yeah, it's a lot back. I didn't realize that. So the saying is that, not this one, but that one illustrates what I'm saying is only half of the returns, only half of the difference between, let's say, cardiologists and the others is explained by these three factors, because they work longer hours, because they have more training, longer training, and because of the skills. The skills, I think, if you say that's more prestigious to be a cardiologist, because more likely the people with more interest or more intellectual driven, I don't know, going to be going that. I'm not saying, of course, this is on average, that's not necessarily mean that the other cards are not driven by intellectual challenge. But the point is only half of the difference is attributed to these three factors. What means is the other half of the difference is probably due to entry barriers. No, and that, as I said before, right? The supply side is not catching up in much of the count, right? And that's probably something to think about, right? To say, okay, what's happening in the supply side that is not catching up, even though you have excess of demand for training. I mean, there are much more people willing to be nurse, doctor, or dentist than training available. So, and of course, from one side, in the influence the rate of returns, because there are less people working, but also from the other side, influence also the cost of education. Because from a very basic economic perspective, if you have more people willing to go for the training, of course, the tuitions are going to be higher, right? So I'm going to stop here with this, and I thank you for hope I didn't bore you too much.